Good afternoon. This is the House Appropriations Committee. It is Friday, February 28th, 2025. It is just after 1 p.m. and we are lucky enough to have Nolan Langwell from the Joint Fiscal Office come talk to us about FMAP and a little bit of DISH. He's going to dish it up just a little. Sorry, I'll stop now.
You said it, but I was thinking it. All right, let me find
You
it.
dish it up, but we can't take it anyway.
Right. For the record, Nolan Langwell, the Joint Fiscal Office, I will share my screen. Try to. I got a new computer, so I'm still learning how to use this thing. All right. So I'm going to talk very briefly about DISH because it's not my area of expertise. I was just asked to just sort of say what it is, and that's what I will do. I will tell you the bare minimum of what I know, and then we'll move into FMAP, which I know a lot more about. So
exciting.
So DISH stands for Disproportionate Share Hospitals. And what it is these are payments that are intended to offset hospital uncompensated care costs and improve access for Medicaid and uninsured patients, as well as the financial stability of safety net hospitals. So these are payments that go to hospitals from the federal government, but through the states to help hospitals offset their uncompensated care. Each state gets an allotment, and the way it's calculated is a sort of statutory way, which is calculated at the federal level. Currently, but then the states actually have a lot of flexibility in how they actually administer it within the state. These are match dollars. So, but in those allotments, it means that the state only is allotted a certain amount of money, which means we can't give more than whatever the cap is. So currently, Vermont gives Vermont hospitals $22.7 million a year in DISH. We're not at the cap. The cap, I think, it's somewhere around 28 million. We're about 6.4 million below what our maximum amount that we can give. It used to be higher, but under the Inflation Reduction Act, there's actually a reduction in what that cap is. We weren't hitting the cap anyway. And part of the reason I think the state hasn't gone all the way to the cap is because it would require more general fund dollars to get there.
Do you know what the match rate is?
Regular match.
I don't know what regular means.
41.2 or 42.1 mix.
So we put in 42.1 and they give us 58.
Or 41.2, yeah. 41.2.
Is what we put in. Okay.
41.2% of it is what we put in. There was I think back prior to 2017, we put more into DISH, and then it went down. And then there was this 1 year where we had what we called double DISH, and there was some anomaly with the time changing of the years. So we gave them like 44 or $46 million, and then it's been at 22.7 million, I think, for.
22.7 million is our share?
That's the gross, sorry. That's the gross amount. And so DISH has been at 22.7 million for several years now.
Okay. Okay. Lynn, did that answer your question, or do you have another question?
No, but thank you. You didn't mention the provider tax.
Because they're separate.
Well, they were supposed to be linked.
No, technically, they're not supposed to be linked. They were part of the same conversation. So Representative Dickinson has a very long memory and a lot of institutional knowledge in this. And if you go back, I don't know, 15, 20 years.
That'd be 20 years.
Yeah. There was when we put I don't remember if it was, if you want the real history on this, you would bring in Mike Del Trecco from VAS. He's someone who's very well versed because I believe he was here at the time. But essentially, when I think Vermont instituted the provider tax or increased it, I can't remember what, back 20 years ago or 15 years ago or whatever it was, it was linked as part of a negotiated agreement that would also increase DISH payments. So, as you know, provider tax, and I can talk about provider taxes in a separate conversation after I do FMAP as well, if you really want to hear about that. But essentially, Vermont hospitals pay, I actually wrote this down somewhere.
So, well, let's do provider tax separately. I don't want to get us all.
Okay. But there,
straying from Dish and I,
so Representative Dickinson is correct in a way. I'm not saying you're incorrect. I'm saying that there was a conversation years ago where provider taxes and Dish were had as a conversation for the hospital's agreement to be part of the provider tax going back history. But they are not linked in any way except for that conversation. So a lot of people who have a long knowledge of this think of the two together, but they're actually not the same. Now, I was here back then, so I often think of them the same too, but they're not the same.
Provider tax was a percentage on the gross income for hospitals and they paid it in to the state.
right,
It was it had to be, it was done by Dr. Howard Dean. The issue is that then the state could draw down more federal money.
Right.
Sometimes it would be called a meta scam. If you talk to Ann Donahue, she can give you a better history of it. But anyway, the bottom line is that the dish payments were then going to be rebated back to the state, I believe from the federal government.
So the way it works.
But it would
now-
make those hospitals that had paid in whole, so it would be no harm there.
And there are all these rules around provider taxes, you know, if a hospital pays you $1, you can't ensure that they get $1 back,
Mhm.
right? So the way it goes back to them is in through Medicaid reimbursement rates.
Right.
So a hospital that has a higher Medicaid payer mix is going to get more Medicaid dollars back.
Yeah.
And DISH is another way for Medicaid dollars to flow to hospitals. Currently, hospitals pay $209 million. That goes into the general fund. And the general fund dollars are used, well, it used to go into a special fund to go back to the
right.
Stone Ages. It used to be going to this fund called the State Healthcare Resources Fund. Provider taxes, claims taxes, a bunch of other things went into that fund. And that money was used to draw match. Now it all goes into the general fund. So it goes into like the conversation about, I look at the general fund as like the ocean. And we're putting water into the ocean and then we're taking water out of the ocean to draw a match. That makes any sense. I've lost you.
It's,
Okay.
yeah,
Okay.
right. We
So anyway, we
have
won't
a
go.
provider tax line on the, yeah.
Yeah, so anyway, that's not why I'm here to talk today. I'm here to talk about FMAP. So FMAP stands for Federal Medical Assistance Percentage. Why is my computer is being, there we go. So I want to start off with a little bit of context. So as you know, this total state appropriation is 8.69 billion in 2024. 2.3 billion of that is Medicaid. So 27% of our state appropriation is Medicaid. 40% of our federal, sorry, 30, so our total federal appropriation of that 8.6 million is 3.17 billion. So 36% of our state budget, the federal dollars, 40% of that 36 is Medicaid. And most of that is FMAP.
Oh, most of it.
Yes.
How much is that in
The
dollars?
Medicaid. So I'll get to that.
You'll get to that.
Yeah, so most of the federal funds in Medicaid, not most of the federal funds,
Right.
but 36% is our federal percentage, 40% of the 36 are are Medicaid, and most of that is FMAP. Not all of it, but most of it is FMAP. There's also some federal grants and some smaller pieces, but
That's the lion's share of it.
lion's share of it is our matching dollars from the federal government
Okay,
for Medicaid. So total, I'm using 24 numbers because the time I did this, I didn't have the 25 BAA numbers in yet. We're still in fiscal year 25, so I can't give you what we spent. We're still spending it. But our total 24 overall expenditures were 2.3 billion gross. And you can get
state gross, just to remind everybody, that's federal and state.
yeah, that's total federal and state dollars combined. So to my other conversation before, you can see, so 62% oh no, I'm sorry, this is a different thing I'm thinking about, forget it. So Medicaid is funded through a combination of state and federal matching dollars, that's what we say gross. The federal government allows state expenditures, allowable matches through what we call, again, through the federal medical assistance percentage. Like as I said, most, but not all of our federal funds for the state's Medicaid or FMAP, just most of them are. So federal matching dollars range between 50% to 90%. So for every dollar, we get, 50% might be spent, might be federal or 90%. And I'll get into the different ranges of what is in the different percentages, and it depends. But our total in fiscal year 24, total federal participation accounted for 62% of overall Medicaid spending. So we have different federal matching rates. And you push it all together in the bucket, on average, the federal government paid for 62% of our Medicaid.
What percent?
62% in 24. And we have different matching rates, but that's on the average when you put it across and you're like, okay, how much was the state share in the end? How much was the federal share in the end?
So we had a lot of things that were over the 50%, and the
No.
average is 62.
Yeah, I will get to that in two slides away.
Okay.
So this slide really is just to give you a sense of like, well, what goes in FMAP and what does it look like in other states? So, and you have to be careful when we say FMAP. FMAP's really the federal share. So when we say, oh, if FMAP's 41.2%, actually that's the state share. The FMAP would be the 58 or 57.9% is actually the real FMAP, but we're talking about, we only care about what we pay in state share. So, but that's just being technical or splitting hairs. But so the way it's calculated is it's based on a 3-year average of state per capita personal income compared to the national average. That's not easy. It's much more complicated than that when you get into the weeds of it, but that's kind of the high level description of it. And so in a sense, whenever you can roughly say when our FMAP goes up, which means the federal government is paying for more,
Right.
means that our state per capita income over the last 3 years has actually been down compared to the rest of the country.
Right.
And vice versa, when our FMAP is down, which means that suddenly the federal government, we lose a little bit in FMAP, it means that, and it costs the state an extra, buck or whatever to pay for a service. It just means that our per capita income is a little bit better. And so it's weird, like, so when the FMAP goes down, just our base, like it just either costs more or costs less just to provide the same service, depending on if it goes up or down.
From the state.
For the state, yeah. So if the FMAP goes up, and the federal government's picking up a little bit more of a share, it means that we're saving a little bit of money. Like this year, the FMAP went up a little bit. I think we saved $15 to $18 million just for our base services, right? If it goes down, vice versa. That's why also you'll find that when there's been an economic downturn, one of the first things that the federal government did, they did it in the Inflation Reduction Act and all the other COVID stuff. They gave states extra FMAP because they know that providing additional FMAP provides fiscal relief. So 6.2%, we had a 3-year period where 6.2% additional FMAP. That translated to about $22 million per quarter. So we were getting almost $80-90 million per year extra in FMAP for that, that period of time. Because that's one of the ways that when the states are reeling from a pandemic or an economic downturn, that's an easy way for the federal government to provide some fiscal relief. Because when there's an economic downturn, who are the people that tend to be hurt the most are the most vulnerable. The most vulnerable are on Medicaid. So this allowed states some flexibility to provide that service. No state can receive less than 50% or more than 83%. And this is important because I'm going to come back to this at the end. So if you look to the left, I have an example of all the New England states. Actually, if you look to the right, you see all the states that have 50% FMAP. And these are all your very high economic states: California, Connecticut, Massachusetts, New Jersey. Those are the states that tend to have a lot of wealth or a lot of industry. We think of like states like New York and Massachusetts just having a lot of money. They have a high per capita income. So those are the states that have the highest FMAP. And then the states, so actually they have the lowest FMAP. They get the least amount of federal assistance. And then the states that have the highest FMAP are the states that we tend to think could have the lowest economic. Mississippi, they're at 76.9%. West Virginia, Alabama, New Mexico. And then on the far left there, you'll see those are examples just to see how we compare to other New England states. So you can see Connecticut, New Hampshire, Massachusetts, they're all 50%. Rhode Island's at 57. Vermont's at 59. Maine has the highest FMAP, 61.3%. And if it has a little up arrow or down arrow next to it, that just means the FMAP went up or down from the previous year. So you'll see 59.01, that's the FMAP. So when I said, oh, it's 42, actually last year was 42 point whatever, right? So 41 point, I can't do math in public. Anyway, that's the federal share of the, sorry.
Dawn, how does a 59% here for, in a couple slides previous, you had 62%.
So this is our straight FMAP. We have multiple FMAPs for different things, and I'll get to that in a second. That's a great question. I'll show you, and I think it's the next slide. Actually, this actually leads into it because my last bullet here is states also receive enhanced FMAPs for the Affordable Care Act. So my next slide actually shows you our
Before you go to your next slide,
Sure.
just correcting a little typo.
Oh yeah, there's one on this, isn't there?
After 50%, it's not of, it's or.
Yes.
Mistake.
There is. Yes.
Just for your next
Of
presentation.
course, you wait till Emily comes in to embarrass me.
I tried to do it earlier, but you were still talking. She didn't hear a thing. She has no idea what I'm talking.
I'm just kidding.
Speaking of corrections, if I may, that lady that came.
Mm-hmm. That's my stepdaughter, Jordan Zimmerman.
Sure.
Is he always joking at home too?
It's lame, right? We probably will appreciate them at least as much.
Welcome to the State House.
This is probably what, your second time? You did a school trip here once, yeah. Right. So the next slide gets to the question of what are the other federal matches. So the top one is our regular match. So this is the majority of our programs that get FMAP. Get this, 58.81 federal, 41.2 state. So this is the 26 rates. These are the rates that we're building the budget on right now. So going to fiscal year 26, when you get the budgets in front of you, these are the FMAPs that we will be using. So for every $1 we spend in Medicaid, we get $2.43 of service, which means that we're putting in one state dollar, we're getting $1.43 from the federal government for a total service of $2.43. Now, this works both ways because there's some people that say, hey, you're leaving money on the table. We put $2 in, we'd get $4.86 worth of service. But it works the other way too, because when you cut $1, you're losing $2.43 worth of service. So it cuts both ways. So that's why a lot of times when we're looking for, like, if we go into an economic downturn, we don't always look to Medicaid, because if you cut $1 in Medicaid to save general fund, you're cutting $2.43 of service. So it cuts both ways. We have two other FMAPs. We have our enhanced FMAP for our Children's Health Insurance Program. This is roughly 70-30. It's 71.17 for federal and 28.84 for state. This is for our Children's Health Insurance Program. There's about 4,400 kids in the program in Vermont for whom we get this match for. Our second enhanced FMAP is for what's called childless new adults. This was the major expansion population under the Affordable Care Act. This was that population where the federal government was looking at states to say, okay, we're doing these expansion populations. We're going to cover more people than were covered. And there was two ways it was done at the time. You had some states that didn't have any expansion populations. And so because they didn't want to spend the money. So the federal government enticed those states by saying, we're going to pay for those folks at 100% FMAP for the first 2 or 3 years. And then slowly over time, we'll move to 90-10. But then the states that were already covering these people, so a lot of these folks were already covered under Catamount Health or VHAP, which were programs that existed at the time. And some of them were uninsured. But states that were covered were like, wait, that's not fair that they're getting, we've been doing this all along, we're paying for these folks and they get a free ride. So on our end, for states like us, it was like, 80-20 for that group. And then over a period of 3 or 4 years, they moved from 100 to 90 and we were from 80 to 90. So now all those populations for all those states are 90-10. There's about 35,000 childless adults that we get FMAP for, an 90-10 match on it. About $225 million in expense
And childless,
for this particular group. We have about 35,000 people and it's about $225 million in gross expense.
so
And we're getting 90-10 match on that.
225 million, and did you just define childless new adults again?
These are folks who are lower income, who don't have children.
What about, is there an age thing? It's the new part that I was always throwing me off.
It had to do, this is,
19-year-olds, I mean,
Well, yeah, so there's nothing to do with immigration. So if someone turns 18, they're, I assume, living on their own, they're a new adult, or if they're living at home.
yeah, so we call it a new adult. Don't let the name fool you. We call it new adult because it was a new population in our program. They're not newly adulted. Is that a word, adulted? It's the title, the name of that particular. So as you know, we have these things called Medicaid eligibility groups, aged, blind, disabled, et cetera. So this was a new Medicaid eligibility group that was created, and it was just, for whatever reason, it was called new adult because it's an adult group and it's a new MAG. So we're just calling it our new adult MAG, but they're not really new adults.
Right, so.
It's a bad name.
This one up, yeah.
Not it. Not it. I don't actually recall. I mean, I was here when we did that. I don't remember if it was a diva thing or if it was a federal thing. So
We
the
can
don't,
vote on changing the name.
Does it matter how old they are?
No, it doesn't. That's what the confusing thing is. It has nothing to do with their age. It's
Child- so-
newly.
what it should be called is
eligible for Medicaid.
childless adult is really what you call it.
What's the dollar break? I mean, what's the income level that's eligible?
I want to say it's about 138% of federal poverty, but I'm not an expert.
It could be one.
Well, I can look it up. I don't,
What it would be helpful to know is the dollar amount, general fund dollar amount in each of these three categories. Yeah.
what the FMAP, well,
No, so if we spend 2.8 billion or whatever on Medicaid, how much of that is FMAP, how much of it is CHIP, and how much of it is childless new adult?
so I can give you some numbers. I knew you were going to ask me some. All right, so I'll use our 25 BAA number here.
Great.
So our CHIP population, our total expenses are 13 million.
13 million general fund.
Yeah, so 71.17% or 28.84% times 13 million, that's the state share for that. Right?
So the 13 million is the whole, the
Total, yep.
Oh, 13 million is the total?
The gross.
Yes. So times that by 28.84 and you'll get a sense of what our state share is, right?
I'm gonna do
I've
that.
never been asked this. I've done this presentation a million times. No,
You haven't been here to, that's why.
true. I should know better.
You should absolutely know better.
Not just a funny committee.
We're not just funny, we're also serious about it. 3,750,000 rounded. 3.75 million.
Right? And then for our childless new adults, the 25 BA is 224 million.
224 million. So 20, no, total. So 22.4 million general fund.
Times.
No, 22.4 million because it's 10%.
2.4.
Okay, and then FMAP, that's gonna be the harder one.
Well, that one was kind of funny because then you started getting into all this miscellaneous and there's some, so this is where it gets even weirder. Reason why we can't do this, because what I don't have in here is for administrative stuff, it's 50-50. So if like Diva is doing something and it's an administrative process, it's 50-50. So that's built into their budget. So like they're doing a service or a program, it's 90-10, but then the administration section of their budget, a lot of it's.
That's all right. This gives us a general idea.
So that's why I'm not wanting to get into the weeds. It's not that simple. You know what I mean?
But we're just sort of saying broadly. So what's FMAP broadly? What's the total in FMAP? Or is there any?
I couldn't tell you off the top of my head. Just because everything else falls into FMAP, or federal match, or some, at the bottom line, some of it's pure state dollars. Like, I don't have that broken out. The other ones are easy because it's right here. But then there's everything else, and some of it's pure straight dollars, some of it's 50/50, right? And some of it's at straight FMAP. So I can't answer that.
All right.
I'm sorry.
And then Wayne.
Is that the mixing bowl when you mix that regular FMAP with all the other stuff? You break it down for each division and each department, each,
They break it down, the department has to break it down. I couldn't answer this specific question, but they know, okay, here's our spend, here's how much we spend on personnel, here's how much we spend on,
yeah, and then it's.
Supplies, here's how much on program, and then they know how much each of those costs, what match they get. And some of it, they might even split, like, okay, some of it's 90/10, some of that service, you know, it depends on how much
That's
it's
what the mixing
allocated.
bowl shows,
The mixing bowl doesn't show that level of detail.
but it shows general fund versus federal fund versus global commitment.
Yes, it's all in the mixing bowl,
It's
but
all in those,
but it's all mixed in. It's like the different mix rates would be like your salad dressing,
yeah,
right?
that's the one place where you can see where they kind of all go total.
Usually we're totals, yeah, but you can't break it out by the various, okay, what is 50/50, what is 90/10, what is 70/30, what is what is 50?
Okay, because I think what the chair was asking for, and I understand that there's a whole bunch of other stuff in there administratively and other stuff. I think she's asking for the gross of what you do for that regular FMAT. If it's
Yeah, I can't break that out.
295 million, or is it 110
Sounds like
million?
it's billions.
It have to be
So
billions.
here's the thing, so you have 2.3 billion, right, or
So subtract the other
2.1.
stuff from it.
No, so subtract the two we just did,
Yeah,
and then whatever's left, there's still 50/50 and straight match and 100% state funds in that. And I couldn't break that out for you.
58 and 58.
Exactly. So that's the mix of the other, right? Because we have stuff like, for instance, we provide services for children with immigration issues, right? And, that's 100% state dollars, right? So that's why I can't break that out for you at the moment. And I don't know that I could break it out because then I have to go through each service line and say, okay,
Right.
so it's a great question, but it's not something that I have the ability to get into the specifics on in the bigger picture. I can do the small ones because we know what those,
Yeah,
so
well,
apologies.
somewhere somebody knows that information, I'm guessing, but
I could ask the HS if you really want to know.
at some point they might, but
Okay.
if it gets worse in Washington, I mean, it just feels like it's something that we have to understand.
Absolutely. And I'm going to get into that a little bit at the end of my
Okay, great.
presentation. Yeah.
Let's ask Wayne to have this
And
question.
that's where my question is headed. So statewide Medicaid, all the many programs there are, what's the grand total amount of money, federal money that we're getting through the Medicaid, all of sundry Medicaid sources? And then what happens if anything goes south at the?
That would be, I have that number, just not with me.
Okay,
I can get back to you on that. I have that number at on my computer.
and I would think if you took that number and then how much money we spend in federal funds, then all those, we could get a percentage that was a conglomeration of all the percentages together and be able to say, okay, we get an X amount of total federal money, and that requires X amount of general fund money, and that's a certain percentage, divide the two.
Well, that we know how much general fund, how much federal funds, how much special funds, right? We have that. I have that. But the question the chair was asking was, okay, of the federal piece, how much of it is straight FMAP? And I'm like, you can't, in that federal bucket, it's all the FMAPs
Yeah,
combined, and I can't
I
differentiate.
understand that.
But what I can get you is, this is our total spending on Medicaid. I have it. This is how much is general fund, here's federal fund, here's special funds, here's grants or some other stuff, right? I have that. I can get that to you very easily.
I think of what we're all thinking is about is, what might happen if things went bad with Medicaid, and that has been mentioned as something that.
Well, what's not going to happen is they're not going to completely take away federal dollars. They're going to do little things. And I have some scenarios of things that are options, and I have some rough estimates, and I'll do that at the end. Because I know that's what's on everyone's mind. It's on my mind.
I'm sure it's a lot of it. But this history is good, this next.
Yeah. And then this last slide is, speaking of history, this gives you a sense of like, this is what our FMAPs have been traditional. So to make things a little muddier, FMAP is actually done on a federal fiscal year. So but the FMAPs we use is when we convert the federal fiscal year FMAP to our state fiscal year. So we take 3/4 and 1/4 and combine it, and that's how we do our state. These are the state FMAPs. Every FMAP that I'm doing here is mostly a state FMAP, except for the one slide where I compared the other states.
Yeah.
That's the federal fiscal year, because I didn't want to go, because they all have different fiscal years and it was too confusing. But everything else, when we come in and we're telling you like, this is the 41.2, we're talking about our state converted fiscal year, the FMAP converted to our fiscal year. And so what this shows is all the FMAPs, the state share, going back to 2000. And years where where the state share has increased are grayed out, and the years where the has decreased, it's white. And there you can see that there used to be a correlation between the cyclicalness of the economy and our FMAP kind of going up and down. That's sort of all been out the window in the last 7-8 years because of COVID and other things. But this gives you a sense of the cyclicalness of it. You can see we've had good years and bad years, but it tends to be in a block, right? Except for 2023, but that was, again, COVID years. And then we've had a series of times where we've had federal relief. And so you can see on the chart that back in 2003 and 4, there was temporary fiscal relief to states. Then in 2009 through 2011, we had the American Recovery and Reinvestment Act, and we got additional FMAP from that. That was formulaic. And then we had the Affordable Care Act. That one we got what we called the Leahy bump. And that was basically Senator Leahy flexing his muscles as chair of appropriations. Because again, this was that thing where
In Washington.
in Washington, DC, yes, where they were doing all this, they were giving all these states that hadn't been doing a whole lot of expansion, a ton of federal money to get them to play ball. But then states like Vermont that were like, we've been doing all this stuff all along. They're like, nice job, keep up the good work. We're not going to give you anything. And it was like, we felt there was a sense of inequity there. So Senator Leahy put in something that basically gave us this temporary called the Leahy bump, where for a period over a 3-year period, we got like an extra 1% to 2% for that period. It's kind of like, hey, nice job. Here's a little thing to help you out.
We have a question here, Mike.
You mentioned that you could see in the past economic downturns and good times through the FMAP, but if it's a comparison against other states, if the entire country is suffering a downturn, if we see a downturn, does that mean it hit us worse than other states? Because if we all went down, wouldn't it stay?
Yeah, it's a great question. That's why I said at the high level, it's an easy way to describe it. When you get into the weeds, it's a lot more complicated, because then there is that piece, and you have some states like backs out at 50 and they're not going to move no matter what their economic is, right? So yes, and it's a lot more complicated than the way I described it, but that's the easiest way to describe it, basically. And then the last FMAP bump we got was under the Family First coronavirus, and then it was extended a little bit. We got a 6.2% FMAP bump also during that time, actually during this time, and then I think was during the ARA as well, American Reinvestment. When we got that additional FMAP, we also had to stop redeterminations. So folks who've been on this committee for a while are familiar with how the impact when you stop doing redeterminations, people stay on the Medicaid rolls and your costs go up and your enrollment goes up. So during that period of 6.2, we also had the period of no redeterminations. So, and the bottom thing just kind of shows in lines, like it goes up, it goes down as a percentage. So this gives you the sort of, just the point of this is to help show you sort of the cyclical nature of FMAP. And of course, that's under, normal economic time. And, so the last thing I was going to talk about is, which I think everyone's been thinking about, is, well, what's going to happen at the federal level? And, obviously the answer is we don't know. but I've sort of taken several things that I've been hearing about and just sort of did some back of the envelopes. So the first one that I've been hearing about is reducing, so basically as part of the undoing of the Affordable Care Act would be, instead of all that population getting a 90-10 match, would be that they would all get straight regular FMAP. So instead of getting 90-10, they would get the 42, 60, whatever you call it, 58, right? So that 200, so you're paying an extra 30% on top of that 225 million or 223 million that I told you about, right? So that is about 65 to 72 million dollar general fund impact just from that way.
72 million plus added from the general fund that we don't have.
Additional general fund impact, just to, if it went that way, just for what we're doing right now. Like,
Right.
just for our current services.
This is to give us a good idea of how it would.
Yeah.
Yeah, what?
That's if they go from the 90-10 on our childless new adult population to the regular FMAP. So instead of enhanced FMAP to straight FMAP. That's about a 64 to 72. I think AHS might even have a higher number, but that's just my math. So we could say
Close enough.
65 to 75. It's a lot of money.
Yeah, okay.
That's just for one.
What's the rationale for childless adults getting a higher FMAP than the regular?
So that was because this was an extent, so prior to the Affordable Care Act, this group was not eligible for Medicaid in most states. And so as part of the Obamacare, it was to entice states, say, we want you to expand and we're going to help you significantly pay for that because it was their priority to cover people. In order to entice states to do it, they said, we will pay a higher match to do it. Otherwise, states were like, we can cover them now. We just don't want to because you have your mandatory populations and you have your optional populations.
And I think the idea was that more people would use healthcare and emergency room costs would go down and we'd have a healthier population.
Which is part of at the time why they pushed dish prices down. Because they thought hospitals would need less dish, which wasn't the case. Oh, did I open up a can of worms?
You just did. Okay.
Yeah, 2 minutes.
Yeah, I just want to say that, did anybody ever look at the fact that people might have had their own insurance at the time and then proceeded to unload that insurance to go on the Medicaid? I mean, because,
You have to be a certain income.
well, you might have had a certain income.
So we have actually looked at that a little bit, and this gets into the weeds and stuff, but essentially, to back up, the people that are in our new adult population, prior to the Affordable Care Act, this group would have either been on the VHAP program, which was an expansion program that other states didn't have, and that was part of our global commitment expansion. They would have been on Catamount Health, which is, as many folks know, was a private public partnership. MVP and Blue Cross Blue Shield had this product. It was subsidized by the federal government, or by the state government, sorry. We were able to get match on those subsidies. And it paid a lower reimbursement rate than commercial, but higher than Medicaid. So those folks, so when the Affordable Care Act happened, those two programs, or they were uninsured, right? When Affordable Care Act went, those programs went away. So I used to say, shake up the snow globe. And some of those people went to regular Medicaid, some became new adults, some went to the exchange, right? So it's what we do look at in other ways in the state is we have and this is a little bit of a side door. How much time do we have? I'll try to keep it short.
Okay.
But we have this claims employer assessment that we apply to employers. And it's applied to employers that do not offer health insurance to their people. And I don't know what the actual fee is now, but they pay it quarterly. When it first passed, it was basically $365 a year. It was $1 a day. Now it's gone up a lot since then. We've expanded it that if these employers, if they offer health insurance, but the employee doesn't take it because it's too expensive, they pay it. But if the employer doesn't take it, Because if not, then they don't pay it, right? If the person is eligible, there's just all these, so my point is, in our state, because through the employer assessment, we have taken that into consideration. But in terms of people's decisions to drop health insurance versus being on Medicaid, I don't know how you address that. Most time if someone's lower income, but they have a job that offers health insurance, they're gonna take it.
Or they're required to take it. They get kicked off Medicaid if they find out.
Well, they can't get exchange product. So they're gonna be uninsured. They're gonna be uninsured. I think if you offered health insurance, actually, you're not eligible for things. Anyway, we're getting down the weeds. Sorry, I'm gonna go down
All
there.
right, let's keep going here.
Okay.
But there were,
You've said one scenario is that they put everybody on the FMAP, and then that's gonna cost us 65 to 72 million dollars.
Correct.
In 1 year.
1 year. Second thing I would say is, we don't know how they would do this, but they decided to change how FMAP is calculated.
Yeah.
And you've heard me say before, every 1% in FMAP change is $19 million.
19.
Yes. So if they change the formula in any way to lower it, that's $19 million. Another thing that I've heard discussed, which won't affect us,
It's 19 million.
one percentage is 19 million,
So
18 to 19, I'm just gonna round up.
Yeah.
Another one is I talked about how the lowest FMAP is 50%.
mhm,
So this won't affect us, but it could, depending on how they recalculate it. They're talking about lowering the bottom below 50%, which means a lot of the states, California and New Jersey, we get hit harder. It wouldn't affect us unless they change our FMAP,
right.
then it goes
And
below.
do it, right, do some sort of.
Yeah, and if they do all these things, then we're compounding, right? You know, if they get rid of the, if they get rid of the enhanced FMAP for the 90-10 and they lower the base, right? Suddenly you're looking at 100 million, right? Another one that I've heard discussed, and this is to go back to sort of what Representative Dickinson was talking about, is there's conversations about lowering the cap on provider taxes. So right now, the way provider taxes works is that it's you can't tax more than 6% of net patient revenue. So we get $209 million just from the hospitals. And the hospitals are the only group right now that we tax to the full extent.
That's 6.9%?
6%, yeah. We have nursing homes, which are, I think, 4 something. I have this written down somewhere. But I printed it and then I forgot to put it in my folder. But we have provider tax on hospitals, nursing homes. We don't own home health anymore. We have ambulances, which are around 3.3%. And then we have pharmacy. So anyway, but hospitals are the only one that we tax to the full 6%. They're 97% of our provider taxes come from hospitals.
Yeah.
If they lower and say, okay, the cap is now 5%, right? Oh, I had the math on this. I'll just do 1%. That's 20, that's, $20 million. What, $2 million, right? $2 million. Every 1% down is another $2 million.
It's 2 million for every 1%.
Yeah. Because 10% would be 20 million. So yeah, 1% would be $2 million. So just to give you a sense though, like here's little things, there's a lot of screws they can turn. I have a whole list of things that they can do on work requirements, eligibility changes, that stuff I have no way of calculating, but I was just doing the basic number ones.
Has there been any conversations that you've heard or discussions about optional Medicaid services? You have a core group of Medicaid services that everyone provides. And
Yeah.
states can, I believe,
Yes.
like from a menu of
Correct.
services.
Absolutely, yes. And in my Medicaid presentation, I have that slide and it shows you, here's your mandatory, here's your optional. What I can say is that in the past, when the state has been looking at different ways to cut in tough times, well, they've looked at, let's cut this, let's cut that. The majority of the spending is in the mandatory, your inpatient, your outpatient, pharmacy, et cetera. If we were to try to find savings in cutting, dental, right? Okay, you'd save, I don't have that here with me in front of me, save maybe $1 million or $2 million, right? Or if you cut Cairo or, so there's, but you got rid of all of our optionals, it would make a dent, but it wouldn't make a big dent.
I think that's a question.
Any idea where that is? I mean,
I used to. No, because I did that exact, no, to your point, I did that exact exercises back when we were doing tiger teams. Remember those tiger teams?
Oh,
Yeah, so this exercise, I did this exercise back then. I haven't done it recently, so I don't know. It's gonna be millions of dollars, but it's not gonna, in $1 billion program, but yeah.
it's not like the first one, the $65-75 million.
right.
I mean, I don't want to speak out of turn. I don't actually know what that total would be, but I understand your question, and I'm assuming that's one of the first places that the administration would look to as well. Like, okay, do we lower the dental rates? Do we drop Cairo? Do we not do orthopedists anymore, right? But right now, we cover all the optionals. We have our mandatory, then we have our optionals, like the list of things that we're allowed to cover. Currently, Vermont covers all the optionals.
Yeah, I am. So, usually when I'm worrying about this, I'm worrying about the individuals or families who are affected. But I started, then I expanded my worry to what is the systemic impact of this on providers, on institutions? Have
If the FMAP or anything's go down,
yeah.
it depends on how the state reacts, right? If we suddenly have, let's say, $100 or $200 million general fund hole, does the state take that out of Medicaid? Or do we keep a Medicaid hole and take it out of other areas? And if we do take it out of Medicaid, what does that look like? Well, if we take it out of rates, well, then yeah, we'll hit providers, right? If we take it out of coverage or services, well, the providers won't get the reimbursements for that, or they're going to be providing more free care, right? It all depends on how we as a state react to those cuts.
But it's probably not good in any situation.
Probably not.
I mean, if we just backfill, we're losing $75 million potentially.
And think about all the things that we do in government, where we're funding grants and all, is to help people, right? Is to provide services. So if we have to cut, we're cutting services somewhere across state government, whether it's public safety, whether it's healthcare, whether it's education, right? So it's going to affect, it doesn't matter where those cuts are made.
Right, and some of the consequences may be more indirect.
Yeah.
Depending upon how we did it. So,
Yeah.
Yeah,
And we don't know how to react until we know what it is we're reacting to.
right. And there's that. This is this 50-page thing that I got from our former chair yesterday on the different committees in Washington and what the possible places are they could cut. I thought it was just around healthcare, but it's not. I'm seeing agriculture and EPA and other things. So
Yeah, I have a copy of
I
this
don't really know how much I want to read it. It's all depressing.
I have a copy of that too. I have a
Yeah.
copy of that, and I have one put out by FFIS.
Yep, yep.
And it's convert Medicaid to per capita cap system, eliminate the enhanced match rate, lower the maximum to 50% FMAP, limit provider taxes, repeal Medicaid eligibility rule, repeal Medicaid CHIP access rules. So that's eligibility. Establish work requirements, standardize the administrative matching rate.
It's full of comfort and joy.
And we can assume that they're not going to do one, they're going to do a combination. It's just a matter of how much of each.
Right.
they're going to
And
do.
which ones they pick. Wayne.
The tax on hospitals, ambulances, et cetera, what's the name of that tax?
Provider tax.
Provider tax, and that's the federal tax.
No, the state tax. But there are federal rules to go to what Representative Dickinson was talking about with that term metascam. If there was no cap on it, states would be like, great, we'll tax you even more and we'll just get the federal government to match it. So 6% was the federal government saying, we see what you're doing and we're going to allow it a little bit of leeway.
Okay. Do you have more good news for us or any news?
That's another joke.
Yeah.
I'm going to bring you down. I got to bring you back up, right?
I think so.
Does anybody have any more questions for Nolan about anything healthcare. I'm
I have one question.
yeah, go ahead,
When
Lynn.
you look at this, it was your last slide. You're looking at the, the ups and downs of the FMAPs. When the FMAP is down, like it is in 2006 and 7, that means we're having a better economy than we had in 2002.
Now,
Now, I mean,
In theory, yeah, in theory, that's just why I said we were talking about representing it's, in theory, yes, but there's a little bit more that happens behind the scenes. So in theory, there is a relationship, but there's a little bit more to the calculation than just that. But there used to, like I said, there used to be a correlation, but I feel like the correlation is a little bit less so over the last 5 or 6 years.
But you show those areas here too.
Yeah, because there was a correlation. Those, I think more recently, the correlation sort of, the standard rules seem to be out the window these days.
Right.
So is DISH a place the feds could go to?
Yeah, I
Is
think-
that not very significant. And
So, well, we have 22.7 million in Dish. Federal government could say, they could lower the cap on Dish. That wouldn't hurt us. It would hurt our hospitals. Right? We wouldn't,
proportionate share.
unless the federal government says, you know what, now your FMAP on Dish is now 50/50. Right? Then that could, but I don't think that, I haven't seen that being on the table. But just reducing Dish alone doesn't hurt the state budget. It hurts hospitals.
Start losing service.
Yeah.
We have to.
Well, the hospitals have to find offsets somewhere.
They would still pay the provider tax, but what they wouldn't get it back.
Well, they're getting reimbursements back.
Yeah.
We've also done it with reimbursement rate increase, but several years ago, to your point, they wanted a reimbursement increase, so we increased, we were at a lower cap, 5.9%, and we increased it to 6%, and we put that in the rates. Or then we eventually moved, we were used to calculate provider tax on looking on a 3-year look back, and we were able to look back 1 year instead. So you got a 2-year bump because revenues are way higher, and we got like a $20 million bump in 1 year. Well, that money went into rates. So it's not just Dish. That money goes into rates. But again, hospitals, if hospital A put $1 million in, they're not guaranteed to get $1 million back. They get it through increased rates. So if they have a high Medicaid mix, then they might get more back. If they have a low Medicaid mix, they might get less back. But that's the way they can do it. If there was a quid pro quo, that's legal.
You said that we weren't at that max 6% on provider tax for all categories. Why wouldn't we be? It seems like there's no downside to getting the match.
There's a downside for those providers. So for instance, the home health, they were getting taxed, I forget what it was. We did analysis, turns out they were paying more in provider taxes than the state was paying them in Medicaid total.
Okay, I admit, I worked in home health for 10 years,
Yeah.
and the provider tax was an issue for me. And you say that home health's not paying it anymore,
Yeah.
but Choices for Care.
No, the home health as a provider class doesn't pay it anymore. We took that away back.
Yeah.
Or do you include Choices for Care,
If
home-based services in that? Or I think you're probably talking about traditional Medicaid.
It's whatever, if you have a Choices for Care service being provided by a different provider, then it would be taxed. But we're talking about home health provider. So home health
Yeah.
provider doing it, not that we don't do it by program, we do it by provider. I know we went off the rails a few times. I'm sorry.
That's okay. No,
Think about this.
this is a time when we can get your brain.
Okay, so how does Choices for Care get paid? Is that just part of your regular Medicaid? Or is
Yeah.
that,
It goes to a global commitment.
yeah? But
They're
that's
regular.
not part of the home health thing where they're doing the work at home instead of through an agency.
Yeah, no, that's what I'm saying. There's providers and there's services. You had providers who provide that service.
So,
So so they were providing that service, then that was part of their revenue and they get taxed on their revenue.
home health does, or home health did.
Home health did, but now they're not paying the provider tax anymore.
Okay. All right.
And same with nursing home. Actually, we used to do one on intermediate care facilities. We don't have any anymore, so that's out. And just if you want me to go down this rabbit hole, there's a whole other class of providers we can be taxed. We can be taxing dentists. We can others. And the reason we don't do them is because it's too complicated. Governor Shumlin he proposed doing a provider tax on dentists. And the reason it failed was two reasons. One is whenever we've done a provider tax, the provider class themselves has been on board. So when we did the hospitals were on board because they were like, okay, we're going to have this agreement. When we did the EMS providers were like, great, we're on board because we knew we were going to put that money into increasing rates. When dentists who tried doing dentists, like, we don't want any part of it. And so that made it hard because they weren't invested in it. And part of the reason why that matters is in order to tax their net patient revenue, you have to know what their net patient revenue is. Well, there's 14 hospitals, that's easy, and they have to report it. Nursing homes, they have to report it to Dale. Dentists are private companies. They don't have to report anything to anyone. So in order for us to know what their net patient revenue is, they have to report it to us. Well, most of them aren't doing audits. They're not doing these audited financial statements. They're small businesses, right?
The same as independent primary care
Yeah.
groups.
Yeah. So to your point, one of the providers is physicians. Well, independent physicians aren't getting taxed, but physician practices that are owned by hospitals are, because it's part of the hospital provider tax. So you see how it's clear as mud.
If you can't access the information, you're
Exactly.
not going to tax it.
So that's why it failed, because the dentists came out against it, and we had no way of knowing how much to tax them because there was no mechanism to know what their net patient revenue was. So we couldn't even audit the process.
You could say as a condition of licensure, you have to report your revenue sources annually.
Yeah, but that wasn't a part of the discussion at the time, and it was an increased
Well,
expense
It
and.
was for political reasons, not technical reasons. They weren't on
Sure.
board.
Yeah, I think you're right. I think political reasons is a big part of why it failed.
Yeah, I'm guessing that probably was true too.
But from an autocrat or technical, it also was hard to do
Right.
without their buy-in.
Mhm.
And they didn't buy in, and that's the politics of it.
Right. Yeah. Dave, do you have any other questions or comments for Nolan?
No, I've been following this. It's fascinating.
Yeah, it's something else.
What else?
I do wonder though, the physician class, if you were in primary care and things were so bad, like I think they are now, that may seem like it's not the time to suggest this, but when in fact it could be. While there's no quid pro quo, which is illegal, you could infuse with the revenue and the gain we get with Medicaid, you could dramatically infuse the payment rates, but then it becomes how many Medicaid patients are you going to see? You're going to see enough of them to earn it back, and it gets complicated. But we did that with nursing homes, we did it with hospitals, and usually it's been at a time when things are very, very dire. Anyways, just a thought.
Yeah. Thanks, Dave. The federal debt seal or reconciliation drop dead date, whatever, is March 14th. So we'll be back. But I'm sure the news will be all over the place between now and, March 14th, between now and March 14th. 2 weeks, 2 weeks from today, I guess.
Yeah, and depending on what they decide, the budget you're working on could be severely impacted.
Yes.
No.
And guess what? We have a week between then and when the budget's.
I know you're surprised to hear that. I know you haven't thought about it, Representative Stevens.
Is that the graveyard I was whistling by?
Yeah.
All right. Nolan, thank you for your time,
Mhm.
all of this, and it's just good to know as much as we can know, and then we're gonna see what happens. And we aren't gonna have solutions 5 minutes after we know what they're doing. But at least we have this in our brains to be sort of thinking about. So committee, what I'd like to do is take a break and reconvene at 2:15. We'll see, I think some of you have told me you have some other places to close. And we'll maybe review a couple of committee letters, but we'll finish by 3. Okay? All right.